We would like to know how to do Passerless MIO wiring for protein wound from Taiwan, please.
So I will share my limited experience to show how to do the MIO wiring without the passer. Okay, so for this prosthetic fracture, how we could do holder reduction. I think it's a long spiral. I think everyone will agree the circulatory wire can help a lot. So just like that, we can use the circulatory wire to temporarily hold because this stem is stable, so we can put the definite fixator later, so make the surgery easier. But how about this one? It's a long spiral, sometimes with some wedge fragment. But because it's a long spiral, sometimes it's oblique. But I think that the circulatory wire still have the role to keep the reduction, just like that, to make the definite fixator insert easier. Okay, but sometimes, just like this one, again, some wedge over there. But this case, he do the open wiring. So make the soft tissue dissection too much. For finally, we found is got to the non-union. Okay, so in the past, the textbook always say, never try to do the open wiring because there will strangulation of the blood supply. So never do that. But recently, I think we see the more and more trend to try to do the circulatory wiring. But so what is about the history? So first one, we need to understand about the mechanics and biomechanics from the circulatory wiring. And later I will show how to do that. And finally, anything we need to pay attention when we put the circulatory wire. Okay, so start from this one. So maybe 20 years ago, and when the meeple come first, it shows just like that, no touch over there. Try to keep a reduction and put the definite fixator. So especially in this area, this is, I mean, have always have some debate over there. The subtrop fracture, we know we can do the no-touch technique, try to fix it, but we can see the alignment is not so good. So that means when we find the entry is not so easily, and most important, because the bone not very well contact. Finally heal, but take times. So especially in the subtrop fracture, how to keep the reduction, I think everyone agree this is very important. We have a lot of technique, try to keep a reduction and find the proper entry. And just like that, if we can use any way to keep a reduction, that will make our final fixator come easily. So for my personal, I always like fix the near reduced bone because they will make my surgery easy. So around 2011, this is the first the study report use the circulatory wire. He emphasized if you use this technique, you still can see the callus formation just like that, and the healing time will become shorter because the bone have a good contact. So this paper showed if you put the circulatory wire properly, you still can provide the adequate blood supply, and the circulatory wire is not always the absolute stability. Now we looking for the literature, already adequate evidence show because the blood supply for the bone canal is not just in the longitudinal fashion. You have some cross link. So now we know the blood supply is just like a network. So if you just put a circulatory wire, we will not completely destroy the blood supply for the bone. Okay. And another point is because our bone is not purely circular, so when you put the circulatory wires, it just contains some area, still left some space for other bone supply. So under the basic study, after cyclic loading, we still see the cortex still intact. So now we know from the basic, if you put the circulatory wire properly, you will not destroy the blood supply. And in the clinical series, we can find if you put the circulatory wire, you will provide the faster bone healing and better the clinical outcome, less shortening. So I think for my personal, I believe circulatory wire is very good reduction tool if you use it in the proper way. So what is the proper way? It means the soft tissue friendly, to do your best to keep the blood supply. Now we know, nowadays we know that this is a MIO wiring instrument developed by Professor Talatrai. So I think this is a very good way to do that. And his first report, you can apply it in the proximal femur, even the distal femur, no problem, easily. So, and the clinical result is very good. But the problem is before that, how to do that. So because my hospital is not so Even nowadays, we have this instrument just 4 years ago. So before that, I always try to do MIPO wiring, but without this instrument. So if we consider about the literature, we can find that this is not a new technique. So it's already more than 20 years ago. So you use the loop needle to try to pass the wire. And my senior college also reported his technique. Use the soft tube and then pass the soft tube first and then insert the wire. So I think the stuff from the tibia will be easier because the tibia is a subcutaneous bone. And the most dangerous structure is usually in the anterior, just the anterior tibia, artery, and nerve. So if we can just touch the bone cortex from the lateral and pass the posteriorly like that, and just insert the instrument and bring the soft tube, and then we can open the medial side to put another instrument to touch that and pass the soft tube easily. Not so difficult. But for my personal, I think because in Taiwan we have no ball end, ball tip and the wire. So this means that we always cut the wire, so the both end is sharp. So in this situation, for me, I think it's very difficult to through the wire in the soft tube, easily penetrate. So in my hand, usually I use it in this way. So just use the coker, the bigger instrument, start from a little bit lateral, just like that, and touch the bone, go down posteriorly to avoid the injury to the vascular. And then we can turn in the opposite side, the small stepping wound, use a small Hoffman from the medial and then push down. And then we can pass my instrument over there. And then in the medial side, I will hold the wire. I will always bend the wire like that. And I can hold the wire from the medial side. Okay? And then pass. This is most difficult part. And then later it's easier because it's anterior through the medial side. I think it's just a soft tissue, just skin over there, so very easy to do that. But we need to pay attention in the distal tibia because the anterior tibial nerve will come more anteriorly, especially over the metaphysis junction. It's very close to the anterior. So in that situation, I think it's not easy to use this technique in the diaphyseal junction. But luckily, in most diaphyseal fracture, we always can find a big fragment over the diaphyseal area, so we can still use this technique to pass the wire to hold the bone. Okay, so just like that. The soft tissue condition is not so good, but we still can use the MIO wiring to keep the reduction like that. And finally, we still do the fasciotomy, and later, when the soft tissue becomes stable, we put a deafening fixator. Okay. Okay, this is another case. Not so difficult. Okay, but how about the femur? The more soft tissue over there, more vascular. Is it still possible? We know that the two major dangerous structures, first one is superficial femoral artery, another is deep femoral artery. I think another team from Korea already reported their technique, but it's just emphasized for the distal femur. Okay, just like that. So if we want to do this, we need to consider about anatomy first. Again, Professor Terachai already do and Professor O already combined do the serious study to show what is the dangerous structure over there. So from his paper, we can know if in subsequent area to the mid femur, always from the lateral side, because the medial side has the two major structure over there. From medial side is too dangerous, so always from the lateral. How about the middle to the distal? I think just contact the posterior cortex, pass the wire passer, they will make safer. Okay, so in my personal, if I have no wire passer, in the proximal subchore area is very dangerous. So always just can come from the lateral side. But for middle or for distal, I think still have some space to do the MIO wiring without the wire passer. So this is my way. But similar to the Korea team, but for me, I think because if I run in this fashion, the medial side will have strangulate some soft tissue over there. So in my practice, I always, just like this case, I always make the bigger incision in medial side. And I always make the knot left the medial side because I want to see nothing strangulated by the circulatory wire. So just like that. Okay, I can develop vision and temporary hold, put a deafening fixator like that. even for the middle in the same way. Okay, and make sure no intra-articular extensions, stem is stable, the temporary fixed with wire. So my wire nut is always over the medial side. And then I can put the definitely fixator and bend the plate to properly. Okay. So how about the structural? I mentioned about that. If I want to do another incision from medial, is too dangerous. So in this situation, my only choice is the traditional wire passer, but still try to make the soft tissue, less soft tissue dissection. Okay, so finally, we still some tip we need to pay attention is, I think, according to the Professor Terachai, his study always mentioned about that. Even we use the MIO wire passer, still have some chance, around 20% to get injury to the perforator. But in that situation, the perfusion still can be maintained. But if we consider about literature, we always can find some case report just like that. Incidence is not so high, but sometimes it's very terrible. Sometimes the patient BP drop, or some have ischemia limb. If you pay the attention to this situation too late, finally you got the ischemia limb. So the most severe complication, we need to do the amputation. So when we put in this, even we use the proper instrument, we still pay attention, keep in mind what is the dangerous structure over there. So this the final two cases I want to share. So this is the young lady, a little bit interesting, not a big complication. Initially, I put the plate, but reduction is not so good. So I put the circulatory wire first and put the fixator. And finally, it's healed. But when it healed, we found another couple years later, the wire broken. And then got the migration, caused some irritation. So finally, we need to remove that. This is another case. Again, wiring and nailing. Even we remove the implant, the wire looks still okay, but 1 year later, wire broken. What happened? I think, for me, I think might be one reason is the remodeling of the bone. So finally, the wire got broken because I still have some force over there. So nowadays, in my hand, I know this one can keep the good reduction and will destroy the blood supply. So I will always try to do that to keep the reduction. And in structural area, I just hold it, not make the wire too tight, left some space over there. In structural, because this area, I think mechanics is still very important. So I will left the wire over there. But in other area, just like that, if the bone quality is very good, when we put the damping fixator, I think the stability is okay. I will remove the wire. Okay, so this is my last slide. Now we know this technique, we can use it properly. It still can help the reduction and keep the blood supply. But most important is when you want to do that, the less soft tissue dissection. And how to do that, you can use wire passer or without the wire passer. But in the proximal femur or in far distal tibia, especially around the metaphysis junction, I think with the instrument will be safer. And most important, even you have the proper instrument and proper technique, you still keep in mind what is the dangerous structure over there to prevent the complication. Okay, thank you so much.